Hello. Today we're going to be talking about risk factors and prevention for perinatal depression and anxiety. So first I'm going to be talking about risk factors for developing perinatal anxiety and depression and risks associated with perinatal anxiety and depression, and then strategies to prevent these conditions. So perinatal depression is the most common complication of pregnancy. It affects 1 in 7 women. In some populations, that number is much higher, and in low-income mothers, 1 in 3 will be affected by postpartum depression. We know that postpartum depression also has a pretty high rate of recurrence. Over 40% of women experiencing a postpartum depressive episode may experience a recurrent episode in subsequent pregnancies. So why is it important for us to identify and treat and try to prevent perinatal depression? Because we know that it's associated with significant risks. So we know that depressed moms are more likely to have difficulty with taking care of themselves and overall functioning. And so how that might play out is poor nutrition, not attending perinatal appointments, difficulty taking care of her children or working. She's more likely to self-medicate with substances such as nicotine and cannabis, which we see unfortunately fairly frequently, but also with other substances like alcohol and opiates. She's more likely to have preeclampsia, more likely to engage in non-suicidal self-harming behaviors such as cutting, and more likely to commit suicide. And suicide is actually a major cause of perinatal death. Also, we know that perinatal depression is associated with preterm labor and low birth weight. So depressed people tend to have more negative behaviors and less positive behaviors, and we certainly see this in perinatal depression as well. So depressed moms might have negative behaviors like not making good eye contact with their baby, not interacting with them, maybe reading or singing, and they will engage less likely to comply with safety practices. We know that they also have lower rates of preventative health care and vaccination, more problems with breastfeeding, and they're more likely to stop breastfeeding earlier than non-depressed moms. And of course, as you imagine, looking at this picture, for example, bonding can certainly be really affected in a negative way. If mom is just so depressed that she's just isolating from everybody, it's really hard for her to connect with her baby as well. And so what this can mean down the line is that there is an increased risk for long-term cognitive impairment, emotional difficulties, and behavior problems. So some of this reflects mom's negative interactions with the baby, but also we think that some of this has to do with what's going on in mom's body when she's pregnant, and maybe the stress hormones like cortisol sort of coursing through. So perinatal depression can present in different ways. So on the more mild side, baby blues, and then sort of more moderate is subclinical depression, where she has some symptoms of depression, but not enough to meet criteria for a major depressive episode. Or she might have an adjustment disorder with depressed mood, where the depression is due to a identifiable stressor and sort of resolves as the stressor resolves or as she gets more support. So baby blues is pretty common. It can happen in up to 85% of women. Typically resolves within 10 days postpartum. And how it can present is with mood lability, tearfulness, anxiety, and irritability. I like this picture because this sort of depicts what a lot of my patients have told me, that they just feel really overwhelmed, especially, they're getting a lot of attention maybe in pregnancy, and then that attention shifts to the baby, and they might have of a support system that's there for the first few days that leaves, and then all of a sudden mom's like, oh my gosh, how am I even going to do a load of laundry? And she might be really, really tearful. So, some of that's just probably due to sleep deprivation and the stress of having a little life to take care of, and most likely it's also due to hormonal changes. But it should not cause significant functional impairment. It shouldn't affect mom's ability to bond with the baby. It would not last more than 2 weeks. would not be associated with any suicidal ideation or thoughts of self-harm. And there's really no specific treatment other than reassurance that this is going to get better, this is very common. And I also find that it's helpful to provide education to our patients to let them know before they deliver sort of what to expect as far as normal baby blues and what symptoms to look out for that would be more concerning for a major depressive episode. So major depressive disorder is the more severe side of depression. It's a depressed mood that lasts for at least 2 weeks and or significantly decreased interest or pleasure for 2 weeks, associated with at least 4 of the other symptoms like a significant change in appetite or sleep or loss of energy, feelings of worthlessness and guilt. So a lot of times moms will just feel like, they're a bad mom. They feel guilty that they're not doing the right thing. The baby's crying and they can't soothe them, for example. Impaired concentration, slowed down thinking and motor activity, or they can have a lot of restlessness and agitation, and recurrent thoughts of death or suicidal ideation. And so this happens in about 10 to 15% of births and can really affect mom's ability to bond with her baby. So the issue with just relying on our DSM-5 diagnosis is there's a lot of overlap between depressive symptoms and normal perinatal symptoms. So in both of these, we would expect to see a change in sleep, change in appetite, decreased energy, and impaired concentration. So if we were just looking at this, all of our moms would look depressed if we're not thinking about their mood too. So we need to focus more on, does she have a depressed mood or decreased interest or pleasure, difficulty, again, connecting with the baby, feelings of guilt or worthlessness, or that sort of slowed down thinking or feeling really agitated and restless. And that's why we use the Edinburgh Postnatal Depression Scale. It really just sort of weeds out all those symptoms that can go along with both perinatal depression or regular perinatal symptoms and depression. All right, so I'll stop here briefly. Does anybody have any questions yet? If so, just feel free to type them in and I can stop. All right, so I'm just going to move on. All right, so we know postpartum depression is common, and it can have, significant risks associated with it, and in some cases, really devastating consequences to mom and baby. However, providers really focus on identifying and treating it rather than preventing it. And a big reason is we just, really, until recently, didn't really have recommendations on what women do we need to be targeting for sort of preventive interventions, and what would be preventive interventions that would be helpful. So the U.S. Preventive Services Task Force ended up commissioning a systematic evidence review to evaluate evidence of potential risks and harms of preventive interventions for perinatal depression in women or their children. So they issued this recommendation in February of this year. And so this applies to pregnant or postpartum women less than a year postpartum without a current diagnosis of depression, but are at increased risk of developing depression. So how do we know, what are these risks that we're worried about, or these risk factors for developing depression, and for that matter, anxiety? Well, it's really multifactorial. So in psychiatry, we sometimes think of the biopsychosocial model, that there are all these different influences that can come into play to affect the mood, and they all sort of overlap too. So on the biological side, there are some things that we just have no control over, like genetic vulnerability. If there's a strong family history of depression and postpartum depression, mom's going to be more likely to develop it herself. Or if she has a sensitivity to hormonal changes, so we'll ask about, PMDD or difficulty with birth control. If she has sleep or circadian rhythm changes, either due to the perinatal period or other sort of conditions, any history of pregnancy complications, so perinatal loss or a history of that in the past, or infertility, or a difficult childbirth, that can increase her risk, nutritional deficits, and adolescent and teen pregnancy. On the social side, one thing I see a lot is unplanned or unwanted pregnancy would understandably sort of trigger some stress. Other stressful life events, low socioeconomic status, lack of perceived support, single parenting, and less than 12 years education. And then on the psychological side, certainly, obviously, if someone has current depression or anxiety or has a history of that, that's going to increase their risk for postpartum depression. Trauma history is unfortunately something I see very often here that strongly contributes to developing postpartum depression or anxiety, and also coping skills that they've developed or haven't developed very well, and self-esteem, which is often sort of a factor of a product of how they were raised, you know. So if somebody has just had all this negative stuff in their head, they're going to think negatively about themselves and maybe their ability to take care of their own family. So the USPSTF recommends providing or referring people at increased risk of perinatal depression to counseling interventions with one or more of the following risk factors. So if they have a history of depression or current subclinical depression that doesn't meet that full criteria for a major depressive episode, significant anxiety, which we know oftentimes can overlap with depression and increase the risk of depression, or other risk factors like low income, adolescent or single parenthood, recent intimate partner violence, or other significant life events. And the reason that counseling is recommended is that was really the only thing that was found pretty consistently through different studies to be effective in preventing postpartum depression. All right, so just want to remind you that MCPAP for Moms can help you with this. You know, and I was thinking maybe it could be overwhelming to think about, gosh, how are we going to start preventing postpartum depression and anxiety? Like, we've been so focused on just trying to identify it, but I think providers are, and treat it. I think providers are already doing this, though. You might not be aware of it, but, you know, I probably get a call once a week where a provider will tell me, you know, I've got this mom that has a history of postpartum depression. She's been fine, you know, for a couple of years. She's not on medicine, but she's really worried about developing postpartum depression again. And so one of the things to ask is, you know, what were the factors that were going on around the time that she had that postpartum depression? Maybe she was in an abusive relationship and didn't have supports, and that's really changed. So she's someone that would probably be, you know, okay without a medication and maybe just some additional support. So what MCPAP for Moms can do is help you sort of walk through that. So as you probably know, we provide real-time psychiatric consultation, and when it sounds like maybe they need additional community support, we can help out with resource and referral linkage with those resources. So there were two types of therapy that were identified as being effective in preventing postpartum depression. So the first one was cognitive behavioral therapy. And so, so what that involves is thinking about psychological problems being based in part to faulty or unhelpful ways of thinking and learned patterns of unhelpful behavior. And so part of that therapy is understanding that people suffering from depression and anxiety can learn better ways of coping and in turn relieving their symptoms. So what that involves is helping to increase awareness of their automatic, distorted negative thoughts that are contributing to problems and look at evidence that refutes these negative thoughts. And then they help them work on problem-solving skills to cope with difficult situations. So an example of this in real life is the Mothers and Babies program, which I believe is available in all 50 states right now. And the website link is on the bottom. So what that involves is 6 to 12 weekly 1 to 2 hour group sessions during pregnancy, and then 2 to 5 postpartum booster sessions. And they emphasize the importance of pleasant activities and social networks, help the patients reduce cognitive distortions and automatic thoughts, and then help develop parenting strategies to secure attachment and promote child development. So I actually went on the website, and on the website they offer a toolkit that providers can use and also moms. And I'm going to show you an example of that, or actually I'm not going to show you, I'm going to go over it. So I found this on their website. It's just a tiny part of a script that a provider would use when providing this type of therapy. Okay, so this is part of the script. So they say, let's look at worksheet 6.5, which lists some helpful and harmful thoughts that pregnant women have. So let's look at this first item. Your clothes don't fit. Now, I may have different reactions to my clothes not fitting. I may have thought, oh no, I can't afford to buy maternity clothes, so I'm not going to have anything to wear. How will that affect my mood? Now, keep in mind, I might also have helpful thoughts about the exact same pregnancy change. So I might also have a thought that I'm proud that I'm already showing, and the world can see I'm going to have a baby. How will that affect my mood? Okay. So moving on to the other type of therapy, the other type of therapy that was found to be effective in preventing postpartum depression is interpersonal therapy, or IPT for short. And that aims to improve the quality of interpersonal relationships and social functioning to reduce distress. So they'll use open-ended questions and role-playing and sort of help with communication skills. So an example of IPT in real life is the Reach Out, Stand Strong, Essentials for Newborn or New Mothers, or ROSE program. And so what they do is they provide 4 to 5 prenatal group sessions, which are 60 to 90 minutes, and then a 50-minute individual postpartum session. And they provide psychoeducation on baby blues and postpartum depression, teach on stress management, they help moms develop a social support system, discuss role transitions, interpersonal conflicts around childbirth, and role playing. I believe they also do some cognitive behavioral therapy in that. And so some of you might be familiar with Dr. Tiffany Moore Seamus. She's an OB over at UMass, and she's actually a co-investigator in this study. So if anybody is interested in getting involved in this, Dr. Byatt will provide Tiffany's information, I think, at the end of the presentation. So an example of this that is actually from the ROSE's website. This is an excerpt from one of their scripts. Having a baby puts strains on relationships. This strain can make it more difficult for you to get the support you need to help you cope with any distress and changes that happen after you give birth. Think about your relationships now. Who is there to help you and give you the support you need? When you size up your relationships, consider these questions. Write down the name of someone important to you and ask, how satisfying is this relationship? Is it supportive overall? How are problems dealt with in this relationship? Are conflicts addressed? Once you size up the relationship, you have to figure out if this is a relationship you want to continue. So I guess I didn't realize that I sometimes do this in my visits with patients, and probably some of you guys do too. But it can be really, really effective in sort of, like I said, preventing depression, just providing that support to our patients. Okay. So there are plenty of other potentially beneficial interventions that we just need more research on. So a lot of these studies, there were some studies on these interventions which were just underpowered and had sort of mixed results. And this is to prevent postpartum depression. So exercise, perinatal education, peer counseling, integrated behavioral health, medication, supplements, infant sleep education, even acupuncture in a small study actually showed some promising results in decreasing the risk of developing postpartum depression in a woman who already had a history of depression. So thinking about medications, there was a study that was done by Weisner and colleagues, and what they did was it was a pretty small study, so they had 14 women that ended up taking an SSRI, sertraline, and 8 women that were on a placebo. And so these women were identified as having a history of postpartum depression in a previous pregnancy, but in their current pregnancy, they had no depression. And so 8 of these women got placebo at birth, right after having the baby, and then 14 of these women ended up getting the sertraline. And what happened was there was a 7% depression recurrence in the women getting sertraline versus a 50% recurrence in women taking placebo at 20 weeks postpartum. Also, the time to depression recurrence was faster with placebo. And once they got to 17 weeks postpartum, the women that were on sertraline were gradually tapered off. And as you might see here, the red line is the sertraline. A lot of these women ended up having a recurrence of depression after being tapered off the antidepressant. So what the researchers concluded was that sertraline prevented expression of postpartum onset depression, but vulnerability to depression manifests after the drug was withdrawn still. And so what they recommended was actually continuing an antidepressant for a minimum of 26 weeks which is consistent with guidelines for a single episode of depression. These researchers had also previously done a study, the same sort of pretty much same sort of study with nortriptyline, and nortriptyline was not found to prevent postpartum depression, at least in the small study that they did. So they concluded that maybe this is because SSRIs increase the brain level of neuroactive steroids as opposed to tricyclics, which might not affect this. So when we're thinking about medication, we always have to realize that we have to weigh the risks of relapse in this case, or of developing postpartum depression against the potential risks of medication exposure in pregnancy, and help the patient make an informed decision. So again, going back to that woman that had a history of postpartum depression, and maybe her situation was extremely stressful back then and she didn't have any supports, and her situation has significantly changed and she has a supportive partner and she's happy about being pregnant, but worries about her risk of relapse of postpartum depression, and let's say she doesn't have any other history of depression, she would be someone where, most likely it would be totally appropriate to not have her back on antidepressants sort of prophylactically and monitor her closely and offer her other supports. Whereas if mom has, a woman has a history of postpartum depression and other depressive episodes, and it's been associated with, significant distress and dysfunction, that's somebody that might need to be on an antidepressant prophylactically. I would probably recommend that. So while evidence is lacking in regards to protection against postpartum depression, evidence that adequate levels of omega-3, folate, and iron protect against depression in general is relatively strong. So we know that iron deficiency anemia and folate deficiency increase the risk of depression. When thinking about sort of providing these supplements, they are pretty low risk at therapeutic doses. There was a study looking at omega-3 fatty acids, which didn't, at least in the study I reviewed, really show preventive effects over placebo and with postpartum depression, but it was actually found to yield small improvements in gestational length, birth weight, and 5-minute ABCAR. So that might be something to consider in women that are especially sort of nervous about taking an antidepressant. So now we're going to move on to anxiety disorders. So anxiety disorders, basically every anxiety disorder is more common in women than men. And I would include post-traumatic stress disorder, which is more of a trauma-related disorder, is also more common in women than men. And the perinatal period is a time where anxiety can be more prevalent. And anxiety is comorbid in up to 2/3 of women that have postpartum depression. And anxiety can present in all sorts of different ways. So it can present just with excessive worries. So around the perinatal period, it might be, worried about something bad happening during the pregnancy, especially if she's had a history of perinatal loss or complications, or worried about baby's safety. She could have intrusive thoughts, which could go with OCD, obsessive compulsive disorder. So a lot of intrusive thoughts typically around baby safety and also mom's own health. Women tend to feel much more vulnerable after having a baby when you realize that you're responsible for taking care of a human being, especially in women with a trauma history. They, tend to be more worried about anything bad happening to their baby. And in some cases, the intrusive thoughts will be really disturbing worries that they're going to harm the baby. I've had a few patients actually tell me they were worried that they would just impulsively take a knife and stab the baby, even though they had absolutely no desire to do that. The protective factor is they tell their partners when they're having this, they tend to be the ones that will reach out and sort of tell everybody to make sure that there's no way that they would actually do that. Sometimes they'll actually stay out of the kitchen while they're having these intrusive thoughts, just to avoid any chance that they would ever harm the baby. They can also have compulsive behaviors, so I included this baby monitor here because a common one is sort of compulsively checking on the baby, again, worrying about baby safety. Is the baby breathing? So the baby might be sleeping through the whole night, but mom's not getting any sleep because she's so worried about the baby. It can present as panic attacks, which is very physical symptoms, fear of dying. People feel like they're dying or having a heart attack or going crazy. They can dissociate. Anxiety is also often associated with sleep disturbance. They can have muscle tension, headaches, upset stomach, impaired concentration, irritability, and fatigue. So needless to say, I don't think any of us would want to feel those symptoms anyway, but aside from just the discomfort, perinatal anxiety is also associated with negative outcomes in pregnancy and postpartum. And it's thought that this is likely related to increased cortisol, which can cause maternal vasoconstriction, which might lead to decreased oxygen and nutrients to the fetus, and in turn could lead to preterm labor, or I should say perinatal anxiety is found to be associated with preterm labor, low birth weight infants, and preeclampsia. And it can also affect infants' response to stress and vulnerability to mood and anxiety disorders. So part of that seems to be, again, due to that like cortisol and the stress hormones sort of coursing through the body during pregnancy. But another part is the behavior that the mom sort of displays around the kid. So sometimes I'll get a super anxious mom, oftentimes with PTSD, that's like really hypervigilant, not really trusting, and she'll bring her kid in, and the kid sort of has the same sort of presentation, which is really sad to see and something I certainly want to prevent as much as possible. So evidence-based prevention strategies for perinatal anxiety are lacking, but I found this from a website with the author noted below. I just like this. So all women do benefit from information, exercise, rest, nutrition, and support, and all those are pretty low-risk interventions. So some non-pharmacological options that could reduce the risk of developing perinatal anxiety are mindfulness, progressive muscle relaxation, yoga, meditation, massage, acupuncture or acupressure, and psychotherapy. So yoga and I believe mindfulness were actually found in some small studies, to decrease the heart rate and blood pressure compared with mom just sitting quietly. And some of these studies found that the risk of preterm delivery and prematurity decreased, and babies had increased birth weight compared to stressed moms that were not utilizing these interventions. One of the challenges that I'll hear a lot, or one of the barriers is, first of all, the cost. There are a lot of really nice apps out there now, and I tend to recommend these to my patients. One website that I really like that's free is called doyogawithme.com, and one of my patients actually told me about it, but they have all sorts of yoga exercises. They have exercises that are just 5 minutes, ones that you can do in the office, ones for prenatal yoga, and they also have some really nice guided meditation that can help with anxiety in general or with falling asleep at nighttime. And in general, these are all pretty low risk. So the other thing is time. But again, there are some interventions that can be fairly quick, 5 minutes, 10 minutes, especially if you're falling asleep or trying to fall asleep. So higher levels of physical activity during pregnancy may reduce the risk of postpartum depression and anxiety. So the ACOG recommends getting at least 30 minutes of moderate exercise on most days. So one thing that's recommended and what I do in my practice is to help our patients plan realistic ways to increase physical activity, because I know that if I'm dealing with someone that hasn't exercised in a long time or was never really someone that exercised, and I tell them to go get 30 minutes of exercise 5 days a week, there's no way that they're going to do it. They're going to feel so overwhelmed that they probably won't even attempt it. So I help them sort of figure out a strategy to gradually get some physical activity into their day. So it certainly helps that the weather is nicer now. So if we've got postpartum mom, you can talk about just taking a walk around the block with your baby for both of you guys to get some sunlight exposure. The other thing is it's important to dispel myths about exercise being dangerous during pregnancy. So certainly some women worry about that. For me, usually the bigger barrier is they say they just don't have time, but certainly some people do worry about, going into preterm labor. So as a psychiatrist, I always tell moms to talk to your OB or midwife or other provider just to determine if exercise is safe for you, but in most cases it certainly is. So when we're thinking about preventing depression and anxiety, we want to also think about potential medical issues that could contribute to developing these symptoms. And so pregnancy is a great time to, check a TSH and a CBC to rule out any sort of anemia that could contribute to depression, and vitamin D level also. So moving on to sleep. Sleep disturbance is a significant predictor of postpartum depression. We know that postpartum women are going to have some sleep problems anyway, most likely, but the significant risk factor seems to be when mom is awake for over 2 hours between 12 a.m. and 6 a.m., if she's getting less than 1 hour of daytime sleep, or if she's reporting more subjective daytime sleepiness. But we also know that, sleep problems pretty much go with any sort of psychiatric condition you can imagine. And, anxiety if someone's not sleeping well, they're also more likely to feel more anxious and depressed during the day. So we want to really support our moms in getting the best rest that they can. So one thing that's really useful to go over is sleep hygiene with the patient. So I would say 90% at least of my patients report difficulty sleeping, whether they're pregnant or postpartum or not. And so I'll ask sort of, what do you do to wind down at night? What's your routine like? And oftentimes, they're doing work on a laptop in bed or, watching TV, or they're pretty active right before sleep. Or I have some patients that'll wake up when they can't sleep in the middle of the night and smoke cigarettes, which is very stimulating. So it's very helpful to go over sleep hygiene. It's certainly much more effective in treating insomnia to have good sleep hygiene, and certainly less risk than using long-term sleep medications in most cases. So one thing is to optimize the sleep environment. So you need to have a preferably dark room and typically a cool room, so you don't want it too cold or too hot. Want to reserve the bed for sleep and sex. Again, don't be doing work, up until midnight in bed and expect to fall asleep because it's unlikely to happen. You want to limit screen time before bed, ideally about an hour, at least before bedtime. So part of that is just it's stimulating. If you're reading something, or again, if you're working, that can stress you out. The other thing is the light from electronics tricks your brain into thinking it's daytime, so it can really mess up your circadian rhythm for a lot of people. Some people still can fall asleep, but it's just, for most people that can be an issue. Don't try to fall asleep. So for some people, let's say their usual bedtime is 10 o'clock at night, and that's when they get tired, but for whatever reason, maybe they want to try to go to bed at 8 o'clock because they didn't get good enough rest the day before. And they keep trying to go to bed early, and they're not tired. And what happens is you start to pair your bedroom with a really negative experience and a stressful experience. If every time you go to bed you're not tired, then you're just, sitting there worrying, oh my gosh, I'm not falling asleep. Soon the bedroom becomes a sort of a negative thing. So ideally try to avoid going to bed until you're actually really tired. Another thing is don't watch the clock. So I personally put my clock upside down so I can't see it at night, and I just turn the alarm on to wake me up in the morning. So what happens with watching the clock is, you're not able to sleep, and you see it's like 1 a.m. and say, oh my gosh, I only have 6 more hours left to sleep. And then 30 minutes later, you're looking at the clock, and and so on and so forth. And you keep just counting down how many hours you don't have to sleep, and that can, needless to say, be very, very stressful and contribute to worsening insomnia. It's ideal to have a regular sleep schedule, getting up the same time and going to bed the same time every morning. Obviously, that can be thrown off when you have a baby. Sleep only as much as you need to feel refreshed during the following day. So some people, if they didn't sleep well the night before, or their energy is really low, they might stay in bed for 12 hours to increase their sleep opportunity, even though, they typically only get 7 hours of sleep and got 7 hours of sleep that night. So that can sort of confuse your brain into knowing what are the cues for when it's actually time to go to bed if you're hanging out in bed, even if you're not super tired, or if you slept fairly well the night before. For non-postpartum people, we want to limit naps to no more than 30 minutes a day, but I'll talk about how that's different in the postpartum period. And certainly minimize caffeine, nicotine, and alcohol. Alcohol is can be very sedating and can help fall asleep, but it can really mess up the quality of a person's sleep, and they tend to wake up in the middle of the night. Also want to avoid heavy meals at bedtime or too late in the night. So sleep tips that are more specific to the postpartum period is actually to encourage daytime naps. because we know that mom's sleep is likely to be very fragmented if she's the one, especially that's waking up every 2 to 3 hours to feed the newborn. So she really needs to get sleep whenever she can get it. And we also want to encourage her to elicit support for infant feedings to increase her sleep opportunity. So it's great if I have, a partner or another support that comes to the office with my patient. I'll really talk about the importance of sleep and try to sort of figure out ways that we can help mom when I'm there with that support person. Okay, so moving on to breastfeeding. So it can be really, really relaxing and a very positive experience, or it can be really stressful for some moms, or it can be both. So, some moms, they've always wanted to have kids. They always, let's say once they're pregnant, they say, oh, I'm definitely going to nurse. I'm going to nurse for a year. All my friends are doing it, whatever. And that's wonderful if everything works out and, the baby's happy nursing and, it's a nice way to bond. But in some cases, mom just might not be able to get a good milk supply, or the baby has difficulty latching. And that can be really, really demoralizing for these moms. They'll tell me that they just feel like they're not a woman, that they're not a good mom, like this is something that their body's supposed to do, and somehow it's their fault that they're not able to nurse. So we want to definitely provide lactation support for women who want to breastfeed or need help getting their supply and are interested in doing that. But we also want to support a mom's decision to not breastfeed if that's just something she never wanted to do or something that she's having difficulty doing. I'll talk to her and say, man, it seems like you're spending most of your day just pumping and, crying because you're not, able to get the supply, and your baby's, also sort of stressed with you, feeling stressed trying to get the baby to latch on. So we might at least talk about maybe supplementing to decrease her stress level. Moving on to family planning, unplanned pregnancy increases the risk of perinatal depression and anxiety, as you might imagine. And about half of pregnancies are unplanned worldwide. Certainly in my clinic, where I'm already seeing women that we know have psychiatric conditions, that number is a lot higher of the unplanned pregnancies. One of those reasons is women with depression and anxiety are less likely to use contraception consistently or at all. So I have a patient that I actually saw earlier this week that, she's got a 3-year-old. She had never wanted to be a mom, and she was in this relationship that was pretty unhealthy where her partner was really controlling and was cheating on her constantly, but she told me that he actually tricked her into getting pregnant so that she'll just be sort of have to be connected with him in some way, forever. And so she's actually been living in a shelter with her son for the past year because the only other option was to be with the baby's father, and he was just too controlling, and she didn't want to do that. So now I see her this week, and she's telling me she's getting kicked out of the shelter because she wasn't being able to comply with whatever their rules were. And her only option, other than living on the street, is to return to living with her baby's father, who she says is not physically abusive, but again, just really controlling. It's just not a good thing for her. And so I asked, are you planning to be intimate with him? And she said, yeah, that's the sort of the only way that she's going to be able to stay there and keep him happy. And then I asked, are you on birth control? And she said, no. And so we talked about, we know this is a really high risk for you. You're not on birth control. You're going to be having sex with him. You told me that he, tricked you before into getting pregnant. And so we really talked about, how to get her set up with somebody that could get her started back on birth control. And I had her make an appointment with a midwife. The other reason that depressed people would be less likely to use contraception consistently is just because they're depressed and they're not motivated really to do anything sometimes, depending on how severe the depression is. Or they'll say, I'm too depressed to have sex, I don't even want to think about that, but all it takes is one time, so I really have that discussion with the patients. And the other thing is sometimes women will worry about how contraceptives will affect their mood. So, one thing that we can do to help sort of decrease mom's stress is to provide proactive and non-coercive family planning counseling and think about potential psychiatric side effects of birth control and try to prescribe some that are less likely to affect mom's mood in a negative way, and think about other potential barriers to using contraception and sort of counsel mom on how to get around those barriers. All right, so in conclusion, perinatal depression and anxiety are common and can be associated with significant risks to mom and baby. We need more research to identify effective strategies to prevent perinatal depression and anxiety, but current evidence supports interpersonal therapy and cognitive behavioral therapy as effective prevention strategies for perinatal depression. Preventive efforts such as strengthening social support, improving diet and exercise and sleep hygiene, and stress reduction can enhance resiliency and have minimal risk. Certain medications and supplements may also play a role in prevention of perinatal depression and anxiety, but more research is needed. So I just want to take this time to acknowledge my colleagues at MCPAP for Moms, which is funded by the Massachusetts Department of Mental Health, and remind you, if you didn't already know, to please call 1-855-MOM-MCPAP if you need any sort of help in supporting our perinatal population. All right, so I will open it up now to any questions that anybody might have. And Nancy, I don't know, are you able to provide Tiffany's contact information?
Yes.
Thank you.
Yeah, that's what I was going to. Yep, so you mentioned the ROSA study, and I'm actually trying to put it in the chat box, but it doesn't seem to be going up there. Beth, do you know how for some reason it's not
Sure, we can
coming
post
up
that for you.
Yeah, for some reason I'm like trying to do it, but it's not working. So yeah, as Valerie had mentioned, Tiffany's a co-investigator in the study, and so the ROSES intervention, basically what happens is people there's some education. It's basically all free if you participate in practices participate in the study, so it's a practice level intervention, and there's some training involved in sort of how the practice can integrate the intervention that they've developed, which has in the RCTs, if they've done, there's been multiple RCTs, I believe 5, that clearly show it's effective. And this particular study that's funded by NIH is really to look at the implementation and to basically help practices sort of implement this by training them how to do it themselves. So and all the resources to do that in implementation protocols sort of provided by the study. So, and our team will be putting up Tiffany more assignments as email if any of you are interested in that.
Thank you.
I don't know if people had, if people had other questions for Valerie. I had a question, Valerie. So if say you're with someone, right? You're with a woman, and it's your first, it's like if we think about the U.S. Preventative Task Force right now, right? So it's like in the recommendation that if a woman's at risk of depression, that we should be referring them for therapy. And, if we're at risk of depression. So I'm curious to know your thoughts about, it's hard to access therapy, right? So I'm kind of curious to know your thoughts about when you're with a patient, for example, midwives or OB and OB providers working, obstetric OBGYNs working, like what would you recommend that people do if they do identify someone, for example, who's got an EPDS of 8 or 9, or they just have risk factors for depression? And
right.
Knowing that it's hard to access therapy, I'm curious to know what you'd recommend that people do out of the real world, because those recommendations are actually pretty hard to implement, right? And also we can maybe talk about how MCPAP for Moms can be helpful with that.
That is a great question. So, I guess the first question is what, for moms that are at higher risk, sort of what is your support system like? What sort of interventions are you willing to engage in? Are you interested in psychotherapy? At Baystate, for example, we have social workers embedded in the OB clinic that can at least meet with women and do some, short-term cognitive behavioral therapy or interpersonal therapy during pregnancy. So that might be one way to sort of get around the difficulty with referring to other therapists in the community. But I think part of it sort of falls on us too. If mom's not able to get into a therapist within the community but does have a relationship with us, maybe for us to just learn some, some basic sort of skills to support her, sort of addressing these automatic negative thoughts, for example, that I'm sure come up even in OB appointments or postpartum appointments. I'm a bad mom, because I'm not able to nurse, and helping her sort of identify sort of contradictions to that negative automatic thought. But yeah, I don't know if you have any other suggestions, Nancy.
Yeah, and I think, we were talking about this in our that's great, Valerie. I agree. That makes a lot of sense. We were talking about this in our meeting around, around MCPAP, and if you do identify women at risk of depression. I think in general, we certainly get calls sometimes at MCPAP for moms for women who don't necessarily meet the criteria for depression, or, the provider may call and say, I'm really concerned this mom, they'll call and say that I'm concerned this mom's or this expectant mother is going to experience depression. She's had depression in her past pregnancy. Her EPDS is now a 9, and, she doesn't need meds, but she's got a lot of stressors, and she's really looking for some support. So I think, from our perspective, that's certainly somewhere we can be helpful in providing, one consultation, like Valerie said, around how you can kind of talk to women, because it's been amazing to us how a few words from their provider can make a huge difference in how they're feeling, their self-efficacy a mother, how they feel about themselves, and like Valerie said, challenging some of those negative thoughts they have, like cognitive distortions around themselves and their ability to parent, or their worries about parenting if they're expecting. And then, and also for us to kind of help consulting around resources and referrals because, we certainly, it's consistent with our mission to want to help women to get into therapy, hopefully, so they don't develop postpartum depression. You don't have to call later. You know what I mean? So that's certainly consistent with our mission, and we certainly, welcome calls around that.
One other
I don't know if anyone has any other questions. Yeah, go ahead.
Oh, yeah. No, I was just going to say one thing that we have around here. I don't know if it's statewide, is early intervention. So once we increase risk of having postpartum depression, we can actually get them referred, and the clinician will start working with mom even before a baby is born, and then work with mom and baby to try to sort of, do everything they can to reduce mom's stress, help with parenting sort of skills, and decrease the risk of postpartum depression. So that can be really helpful. Yeah.
That's a great point, Valerie, and it's definitely, I think that sometimes that's underutilized, because I don't know that I think people don't always think of that, and that's a really important point, that EI is something that can be, early intervention can be really, really useful. I do believe it's available throughout the state.
Thank you.
Any other questions for Valerie? People can put it in the chat box, or can raise their hand, and we can unmute.
Right.
Okay. Well, thank you, everyone, for attending. Just a couple of any further questions, you can email us to at mcpap@beaconhealthoptions.com. And please fill out the survey that we're going to send you. It's super helpful for us to improve these and also know what topics you're interested in. And again, the recording will be available on the website if you'd like to share it with any colleagues. So thank you. Thank you, Valerie.
Yeah.
Thank you. Bye.